Hi everybody, I'm Dr. A. Padmanabhan, consultant pediatrician, and choosing the right pneumococcal conjugate vaccine is a topic of discussion today. If you have to choose the right pneumococcal conjugate vaccine, you have to understand what are the licensed pneumococcal vaccines, which are conjugate vaccines, which are available at present in India. They are PCV10 or Synflorix manufactured by Glaxo, which is sometimes called the old PCV. And then we have the 10-valent PCV, which is manufactured by Serum Institute of India, an Indian vaccine, also called Pneumococcal. PCV13 Prevnar, manufactured by Pfizer, internationally well-known vaccine. And the new entry, PCV14. The reason for me putting up this whole video is because of the entry of the PCV14, which seems to have the maximum number of serotypes, which is also an Indian manufactured vaccine. Now, PCV15 and PCV20 are well available in the Western world and has been included in the immunization programs. Right now, to my best of my knowledge, they are not available in India, and therefore I will not be discussing them in this discussion. When comparing the vaccines available in India, we will have to look at the serotype prevalence of pneumococcal in India at present, individual vaccine coverage of these serotypes, the efficacy, the cost, the opinion of the international bodies like WHO and of course the Indian Academy of Pediatrics, and finally we summarize and choose and try to make a choice among the vaccines which are available in India for public health, the Universal Immunization Program, as well as in one-to-one vaccination in private practice. There are more than 100 serotypes as far as pneumococcal organism is concerned. In each of them, behave as if they are different bacteria. Each serotype behaves as if they are different bacteria. Now, when we cannot look into all of them, but some of them we will be concentrating for reasons which I would say in the later slides. For example, serotype 14, it is a 30% of the invasive pneumococcal disease in the 20 world poorest countries. Is antibiotic resistant also. It present now, if you look at this vaccine, it's a very important serotype, but we would not be very much concentrating on them because when you compare the vaccines, all the vaccines seems to have protection against serotype 14. Therefore, we will not be comparing them. At the same time, as we go forward, you will understand that 3, 6A, 19A, and summer would become more important. One important thing here is in UK epidemiological data up to 2017 indicate that the PCV13 in infants had no direct or indirect effect on serotype 3 invasive disease, and that carriage of serotype 3 continues. PCV13 doesn't seem to have much effect against serotype 3, though it does contain serotype 3. The most recent epidemiological data 2017 also show no indirect effect. For these reasons, this from a Lancet article, though PCV, we will not be giving much credence to serotype 3 coverage because it usually causes non-invasive disease, and PCV13, which contains that serotype, does not seem to protect against the serotype very much. At the same time, we will, for reasons which I will come up in the subsequent slides, we will be concentrating on 22 and 33F, 6A, 14 and 18C, and of course on 19A. These will be the serotypes which, when you compare the vaccine, we have to give some importance. We will have some discussions. The 2009 onwards, these two, I think almost 2010 onwards, that means the last 15 years, these two vaccines have been, pneumococcal vaccines have been available world over. And one is PCV10 manufactured by Glaxo, the other PCV13 Pfizer manufactured. The important difference between these three is PCV13 has 3 different additional serotypes, 3, 6A and 19A. We have found out that PCV13 protection against 3 is not very high, therefore we will not be discussing it very much. And PCV contains, PCV10 does not, the carrier protein in these two are different. The carrier protein in PCV10 is protein D, which is a tetanus toxoid or diphtheria toxoid, and it is the Glaxo company claims that it has some protection against non-typable H influenza, and there is some evidence for that. And non-typeable H influenza causes otitis media. Therefore, they claim that PCV10 has an edge over PCV13 as far as protection against otitis media is concerned, but that is not very well accepted. And whenever you do, though they have some cross-reacting protection on 6A and 19A from 6B and 19F, this is also not accepted as equivalent to having the same serotypes in the vaccine. Therefore, on the other hand, PCV13 has a very good protection against 6A and 19A and not that much against serotype 3. Now comes the new entry vaccine, which is the 10-valent PCV, which is the called Pneumococcal, manufactured by the, I think it's available from 2019 onwards, Serum Institute of India. If you look at it carefully, you would find that it has two additional strains over and above the old PCV, that is 6A and 19A. At the same time, it doesn't contain 3, which is present in PCV13, and we have already discussed that's not of much importance. But note, it drops 4 and 18C. Therefore, it drops 4 and 18C is dropped, and therefore this is of some significance. Now, entry number PCV14 in the last year, that's the reason for putting up this video onwards. The PCV14 contains 2 other serotypes which are not present in PCV13, which is 22F and 33F. We will be discussing it. The most important point to note is it drops 6A. It doesn't have 6A, which is even present in 10-valent PCV, which is Pneumococcal. Therefore, it drops 6A, but it has 2 additional strains, which is 22F and 33F. Now we will look into the efficacy of some of these vaccines. The 10-valent PCV, which is called the Pneumococcal, has undergone the most important studies have been done in Gambia, and there are certain Indian studies also. The studies done in Gambia, 3+0 trial has been done, and it has gone through all the qualification. It has tick mark all the qualification required for WHO pre-qualification of the vaccine, lot-to-lot constancy, etc. But if you look at it, it is not only that. Actually, there are certain Indian studies which have shown that it is effective against 3P plus 1, that is 3 primary doses plus 1 immunization. This is what we give in private practice, 6, 10, 14 weeks and 40 and 1.5 years. You can give from the age of 9 months onwards the booster. That has been studied. 2P plus 1 means 2 primary and 1 booster, which is 6, 14 and 9 months, 6 and 14 weeks and then 9 months, which is given in the Universal Program for Immunization. This is important to note that Pneumococcal has studies for these dosage schedule also. And when we come to PCV14, we will find out that it is not so. It doesn't have the same qualification. But at the same time, every vaccine has its own certain facts which are not kept away from the pediatricians. And many of us may not be knowing that there are certain dark sides also. The Gambian 3-phase trial, double-blind non-inferiority trial, compared the presence of 6A and 19A titers in Pneumococcal with the comparator. Now, they show that it has a very high antibody level when compared to comparator. The WHO guideline document on non-inferiority immunogenicity assessment of new PCV formulations recommends choosing licensed comparators that have the highest number of serotypes in common with the new vaccine, and which is the one which is available instead of. Therefore, they should have they must have been choosing PCV13, which has 6A and 19A. And to my surprise, they have chosen PCV10, which does not contain 6A and 19A, which goes against the WHO pre-qualification guidelines. And they have chosen 6B. They keep you from here. They cleverly keep out the fact that they are compared it with PCV10, which does not contain PCV3. That definitely is a black mark on the vaccine. Now, you may say it also drops 4 and 18C. Therefore, is it not a major problem? But if you look at the Indian studies, and it has been published in the Strategic Advisory Group of Experts, therefore we can't question it. I tried to go into the original studies. I couldn't get the reference. the prevalence seems to be very low, 1.75, and some saying 0%, 1%, etc. Therefore, the fact remains that the prevalence of 4 and 18C in Asian and African countries for pneumococcal is very, very low. But you know, science is a funny specialty. If you look at it internationally, infectious disease or microbiology and parasitology, and they did the study of, they looked at highly invasive serotypes statistically significant from 8 countries, from United Kingdom, Finland, Portugal, Israel, Switzerland, Venezuela, USA. 8 countries they found out where the highly invasive statistically significant serotypes, and 6 out of 8, either both or one of 6 or 18C was present. Therefore, international studies show 4 and 18C are highly invasive serotypes, statistically significant. Therefore, studies done in India and Africa show that 4 and 18C are not important studies. Keep it in mind. And the 10-valent PCV is opposed to serotype coverage globally of 71.7% and India 73%. Now we will look into the Indian studies of serotype prevalence which have been published, some among the most important ones which has been published. The one given in the Purple Book, Indian Purple Book, is a study in 3 hospitals in South Bangalore, which shows a 6A prevalence of 17 and 19.8%. But I do feel that the importance, they have not given much importance to some other studies like the pan-India distribution pneumococcal serotypes, and also which I feel have serotypes from all over, majority, most other states also, not just from Bangalore, and also from the Alliance of Surveillance of Invasive Pneumococcal Disease, which also has multiple states involved. If you look at these studies, there's 6A prevalence in this particular study is 4%. 22F and 33F are very low, 1 and 2% alone. If you look at this study, the 6A is 2.2, and it is only in the Purple Book, which is given in the Purple Book, which has come in IJP in 2025, that the 6A studies, 6A shows 17% and 19A shows 8%. The prevalence of in the other studies are much less. But what is very important, and also 18C, which is not present in pneumococcal, seems to be 8% higher than in any other studies. But what is more important is very few of these studies have studied 22F and 33F, and their prevalence is very low. Remember, the vaccine, these serotypes are present in PCV14 and no other vaccine, and they are 1-2% in this, and it's both together as 1.5%. Now, if you look at and some other studies have shown serotype 22 and 33F to be as low as 0.8 and 0.6%. But you know, in Western countries, when they have done it, after the introduction of PCV13 in 2018, USA had 17% of 23F and 33F, and Canada at 13.8% and UK 10.5%. Therefore, in the relevance in India, it has been 23F is very, very low. Therefore, in other words, 22 and 33F are emerging strains in the West. Already they have touched double figures. But in India, they are nowhere, whatever studies we have done, it is nowhere near it. And these 2 strains are important because the PCV14 alone has these strains. Therefore, this has been used by the new PCV14 vaccine company to say that, look, the PCV containing 22 and 33F have replaced PCV13 in immunization schedule of the USA. It is true, because the pneumococcal conjugate vaccine in 2024 in the immunization schedule up to 2000 in United States is either PCV15 or PCV20, whichever is available. They have replaced even PCV13 because they want the coverage 22 and 33F. But what the vaccine does not tell you, what PCV14 does not tell you, is PCV15 and 20 also contain serotype 6A, which is absent in PCV14. Therefore, if you are aiming to give PCV14 just to cover this, you are not covering 6A, which is an already prevalent vaccine serotype in India, a very important prevalent serotype in India. Our 22F and 33F has so far not been shown high prevalence in India. And further, the PCV14 all the studies have been done with 3+0 schedule. And they are telling that 2+1 schedule papers are ready, but only thing it has not been, they are waiting for the government to act for it. And when you are asking for 3+1 schedule, they are telling that studies are in progress. In other words, only the 3+0 schedule is available, published schedule is, papers are available for PCV 14. That is the big black mark on it, I would say, because 2+1 has to be published to use it in Universal Immunization Program, and 3+1 has to be published to use it in private practice when we give 6, 10, 14 and a booster at 9 months to 18 months. Therefore, many pediatricians are giving this PCV 14 without knowing the studies are not there for 3+1 dose vaccine. Now, if you look at the IPD coverage of by all these serotypes and look at how much do they cover, they don't, as usual, the strain number 3 is not, PCV strain 3 is not taken into consideration for reasons which we have already mentioned. If you look at all the studies, the blue one is the PCV 13, and it is slightly higher. The next comes 10-valent PCV, which is Pneumococcal, and the Synflorix is much lesser. These differences may not be statistically very significant. You may ask, where is PCV 14? Because when the studies were done, the vaccine which came in last year has not been there. We will come to that later. For whatever it is, PCV 13 has a slight edge over Pneumococcal, and Pneumococcal definitely in serotype coverage has an edge over PCV 10 Synflorix. Now, we are very particular about studies about PCV coverage of 22F and 33F also. If you want to look at Indian studies, there are Indian Council of Medical Research in 2023 has put up some data which I made it into table. And it shows that PCV 22F and 33F, there are only 0 invasive disease. They are classified into invasive disease and non-invasive. Invasive is when the serotypes have been isolated, when the organism has been isolated from fluids which are normally sterile, like the blood, CSF, pleural cavity, etc. And non-invasive usually from sputum and bronchial lavage. Now, a total of 149 invasive isolation was made. That's from blood, CSF, etc. Children below the age of 5 years was 37. The rest were above 5 years. And 216 non-invasive was count. Children below the age of 5 years had only 14. Therefore, in non-invasive, the representation of children below the 5 years, which is our focus, is very minimal. Therefore, we will be focusing more on the data from invasive diseases. If you look at it, we are not concerned, as I already said, we are not focusing on non-invasive. If you look at invasive, you will look at PCV 14, which is the one has the Pneumococcal has slight edge over even PCV 14. The coverage is 52% here. It is 51.67. May not be statistically significant, but in no way is Pneumococcal inferior to PCV 14 in the coverage of invasive diseases. And PCV 13 is well ahead in invasive, 63.8%. Therefore, PCV 13, though it contains only 13 strains, in the coverage by the latest ICMR data, its coverage is much higher than PCV 14. For Puritans who would like to cover this, look at the coverage without these serotype 3, again you find that the PCV 13 is well ahead, it's 60.43%. Second comes Pneumococcal, and the third almost same PCV 10 and PCV 14. Therefore, PCV 14 comes only 13, the ICMR data coverage also. Now, please understand that ICMR has got, this is not a study. From whatever data, whatever serum, whatever the samples they get, they made a data. Therefore, it cannot be considered as a double blind or single blind or any type of study, but it's just an analysis of the data which are available with ICMR. Now, we've come to the most important point, was how do we choose the vaccine? That's the topic of discussion. We have done all the hard work, the background work. Plus, please understand clearly that the direct protection rendered by, when we make the judgment, we always take into the fact that the direct protection rendered by the serotype included in a vaccine formulation is definitely superior to any cross protection offered by unrelated serotype, even in the same group in any PCV formulation. There is still limited data. The limited data is one problem we have. We always, like all other conditions in India, the data availability is very poor. Therefore, our judgment can also be wrong. And further, there is absence of head-to-head trials. There's no comparison between PCV14 and PCV10 or PCV14 and PCV13, and never will be one. We are just looking at the serotype, the coverage, etc. We are not looking at the protection. Therefore, the absence of head-to-head trial to make a choice is not. You will be in for surprise to hear what WHO says about the comparison of the vaccine. From 2020, Gavi will offer countries a choice among the three pneumococcal vaccines, one from Pfizer, one from GSK, and one from Serum. So far, the products appear to have equal efficacy. The only difference is in price. My God. And then it goes on to say that WHO expert group on vaccine, the strategic advisory group of experts concluded in a report in February, probably in 2019, there is at present insufficient evidence of a difference in the net impact of the Pfizer and GSA pneumonia vaccine on overall disease burden. And Serum Institute vaccine appear promises to be just as effective. These are sweeping statements, and you will be really surprised. But if you go into reason behind it, WHO would like to have choices so that the vaccine fit into their budget. That is the explanation given in scientific this also, because the WHO contradicts what it says in the next slide itself. The WHO seems to be talking in a different voice also. In the WHO position paper 2019, Sarge recommendation, it says that in the settings of a high PCV on serotypes 19A and 6A, it says that in the settings of a high 19A or 6A, 6A offering cross protection, PCV 13 or other PCVs may lead to greater reduction of PCV than PCV 10. It also goes on to say that cross protection from serotypes in PCV 10 did not appear to offer the same magnitude of benefit as those offered from using PCV 13. Therefore, it clearly says that PCV 13 has the advantage. Therefore, WHO in two different situations talks in two different voices. Now, the PCV 14 company seems to quote WHO, same WHO position paper, and say 6A can be covered well through 6B containing vaccine. But actually, if you look at this WHO position paper, such a statement is not there. We'll go further, but if you look at the pre-qualified pneumococcal vaccines, WHO pre-qualified pneumococcal vaccines, you'll find Pneumococcal, Prevenar, and Synflorix being available. Therefore, if you look at it, there's no PCV14 in that. The WHO has not pre-qualified PCV14. PCV15 and 20 also I did not find. Probably it is not. They are new vaccines, then they are waiting pre-qualification. But PCV14 is not pre-qualified. And what does pre-qualification mean? Is the service provided to UNICEF and other UN agencies that procure vaccines. The WHO has an expert group, and it applies to international standards to see whether these vaccines meet international standards and whether UNICEF and can acquire them. But for individual countries, pre-qualification is not a requisite, but it would be good. PCV14 is not pre-qualified. The other vaccine, PCV13, PCV10, and Pneumococcal are WHO pre-qualified. Now, as far as the choice is concerned, the choice in the private sector is for individual doctors. Please note that all the PCV vaccines have caused a very significant impact in childhood morbidity and mortality. To the extent, never skip pneumococcal vaccination in private practice. Any pneumococcal vaccine is better than no vaccine. Have this in your mind, have no doubt about it. If your patient coming to you is not able to afford pneumococcal vaccine practice, I think all over India now pneumococcal vaccines are available free, and whatever available in the government sector should be given to the child. That's your highly ethical. And as per World Health Organization, pneumococcal disease is the world's #1 vaccine preventable cause of death among infants and children by below 5 years of age. When I was a student, I took my MD and DCH telling measles is the #1 vaccine which is necessary for the children below 5 years, but now it has become pneumococcal vaccine. Therefore, never ever skip pneumococcal vaccination. If your patient cannot afford it in your clinic, send him to the government sector.
I would like to drive home one more point before I go into a choice of vaccine. Mind you, I am quoting it from the Pediatrics Volume 2 in 2019, Invasive Pneumococcal Disease in Children's Hospital in USA, from a very original source. Now, what am I trying to say? It shows that, at least read the first para, the PCV13 serotypes continue to account, serotypes 3, 19A, and 19F, which are there in PCV13, continue to account for nearly a quarter of invasive pneumococcal disease in US children 4 to 7 years after PCV13 was introduced. In other words, even in vaccinated children, they get diseases from which they are supposed to protect. The PCV13 is supposed to protect. Therefore, remember one thing: when you see, don't make a statement when you see an invasive pneumococcal disease in a vaccinated child that a higher valent vaccine immunization would have protected the child. This is a common mistake made by pediatricians, especially in private institutions. When they see a patient with invasive pneumococcal disease, they tell the patient, well, you have taken it from the government sector, it contained less invasive, less strains, and that's the reason why you got it. No, there's a very good chance that even if you have given PCV13, it could still have developed a invasive pneumococcal disease. Even in the US, 25% of the patients after giving PCV13, when they develop invasive pneumococcal disease, are from the strain 3, 19A, and 19F present in PCV13.
We have made the comparison more or less, but some outstanding things which you have to note is in PCV10 Synflorix, it does not contain 6A and 19A. That's a major problem. 10-valent PCV manufactured in India, low cost, etc. The main advantages over PCV14 is available in 2+1, 3+0, and 3+1 schedules are already being approved. And PCV13 ticks all the boxes and used world over till recently, but till it was now it's being replaced by PCV15 and 20 in the Western countries. But in India, the problem is the cost. The cost is a major problem there, and PCV14 now is replacing Pneumococcal in the Universal Immunization Program. The main problem is in 6A, and also the studies are there only +3+0 schedule. That's the problem with this vaccine. The use of PCV14 in Universal Immunization Program, the choice seems to have been already made. On 25th April 2024, the Government of India, exactly probably 1 year ago, has already given a circular telling that in all these states, which marked as green, currently have PCV10, the PCV14 will be supplied henceforth. Therefore, they have made the switch from Pneumococcal to the new PCV14. Therefore, that has already been decided, and the 14-valent pneumococcal vaccine manufactured by Biological E Limited, a Hyderabad-based company, Nubavax 14 it is called, I hope I'm pronouncing it right. The vaccine is recommended for protection of the strains which it contains. The IAP says in the schedules 6 weeks, 10 weeks, and 14-week schedule. And it says it's not recommended for booster dose in the second year of life. But what is it recommended for? What we give in Universal Immunization Program is 6, 14, and 9 months, 2+1 schedule. It keeps silence. It has not recommended it. And that's what is done by the Indian government. And the IAP has kept silence on that. And further, therefore, in UIP, they have switched over to PCV14 from 10-valent PCV. But presently, I would rank PCV14 second to 10-valent PCV. It does not contain 6A. Studies are only in 3+0 schedule, which is never followed in universal immunization. It should be 2+1, for which there's no published studies at the best of my knowledge. and it is yet not a WHO pre-qualified vaccine.
But the choice is already made by the government, the use of PCV14 in Universal Immunization Program, and they have approved it for Schedule 6, 14 weeks and 9 months. That is 2+1 schedule. I already said, I didn't find any published data. Maybe the government has it with them. It is approved it for PCV10 and PCV14. And what's the reason behind it? Because it's a PCV14 is an Indian-made vaccine. They go on to say PCV provides extended coverage against major existing and emerging serotypes. Now, it has never 22F and 30. If they are talking of 22F and 33F, they are not shown to be emerging serotypes in India, and it doesn't offer all the protections against the existing serotype because it does not produce the protection against 6A. Therefore, I have some misgivings about it. It is economical compared to PCV13. Definitely, PCV14 is cheaper by about 1,000 rupees. Understand PCV13, but it is not much cheaper than Numbocil.
Now comes the private sector. In the private sector, which would you test? Times tested, internationally approved, WHO pre-qualified, containing important strains 6A and 19A, maximum serotype coverage, providing direct and indirect effect. Therefore, it has been proved over the years it is PCV13. But there is a major problem. It is cost. It's 4,000 rupees for vaccine. If you have to give 3+1 dose, you are making it at least 16,000 rupees for this pneumococcal this Prevnar alone, and therefore many people cannot afford it. Now, if you want to know what is the number 2 which is available, if I am not giving PCV13, what would I be giving? I would be giving 10-valent PCV because it is approved in 3+1 schedule, and 3+1 schedule is the one which the IAP and everybody recommends for in private practice. Contains 6A, WHO pre-qualified 3+1 schedule. So thank you, ladies and gentlemen, for watching this video. It's been a long one. I couldn't shorten it because I had to do justice to the topic. And I am Dr. A. Padmanabhan, and you can contact me in Padmanabhan _ under this my email address is Padmanabhan. There's an underscore here, a1@yahoo.com, or you can WhatsApp me in 9633794520. Your opinions, your criticism, your doubts will be very much appreciated. Thank you.